ठीक है, बोल देना मेरे
ओके डन सर।
को। ओके, कर रहा हूँ स्टार्ट है।
ओके सर।
Hello friends, welcome. So today we will just discuss previous years INI, CET and NEET anesthesia questions. I'm Dr. Ajay Yadav, anesthesia faculty at DBMCI. So let's start straight away. Question number 1. You are doing a lumbar puncture. Last structure to be encountered will be ligamentum flavum, dura, arachnoid, pia. So this is actually very commonly asked, and very commonly asked that what are the structures which you will encounter when you are giving spinal anesthesia or epidural anesthesia. So just starting from posterior to anterior. So this is posterior, this is anterior. So first to encounter will be obviously skin. After skin, it will be subcutaneous tissue. After subcutaneous tissue, it will be supraspinous ligament, supraspinous, which connect the tip of spinous process. And after supraspinous, it is interspinous. So this is interspinous ligament, which connect the spinous processes. And after that, it is ligamentum flavum, which you know is also called as yellow ligament of the body, ligament flavum. And then you know is the dura, and almost adhere to the dura is arachnoid. So in fact there is no subdural space. So therefore as soon as you pierce the dura, you also automatically pierce the arachnoid. So spinal anesthesia is given here. That is subarachnoid space between arachnoid and pia, and epidural anesthesia is given outside the dura. That means between ligamentum flavum and dura. Now here the question is, you are doing lumbar puncture. Lumbar puncture means spinal. So last structure to be encountered will be, last structure will be arachnoid. So it is subarachnoid. So last structure will be arachnoid. Fine. A 30-year-old male was intubated for surgery. The best method to confirm the position of endotracheal tube is X-ray chest, auscultation, capnography, chest expansion. Actually, confirming the exact position of endotracheal tube is very important, because if you have wrongly intubated, if your tube is in esophagus in place of trachea, then you will directly kill the patient. So therefore it is very important that you have to confirm the position of endotracheal tube. And what all you can do? Many things you can do. You can look at the mist in the endotracheal tube. You can look at this chest expansion. Then you can auscultate and look at the breath sounds. But all these things can misguide you. Even sometimes auscultation can misguide you. The tube may be in esophagus and you are hearing the conducted sounds, which you can misinterpret it as breath sounds. So therefore surest confirmation of intubation is only possible with capnography. Although fiber optic bronchoscopy can also confirm, but that is not practical, and capnography is 100% confirmatory. So we say that capnography and capnography is actually the mandatory monitor nowadays if you are giving general anesthesia. So capnography is the surest confirmation of intubation, and as the name suggests, capnography is the measurement of end-tidal carbon dioxide, that is expired carbon dioxide. And obviously carbon dioxide will come out of endotracheal only if the tube is in trachea, otherwise from where it will come out. So it is capnography. Question number 3. A young male was given regional anesthesia with 0.25% bupivacaine, after which the patient became unresponsive and pulse become unrecordable. The best management would be CPCR with intralipid, CPCR with soda bicarb, CPCR with dobutamine, CPCR with calcium. So it is bupivacaine toxicity. Patient one given block and patient become unresponsive and pulse become unrecordable, means most often this happen if bupivacaine enters intravascular. So then bupivacaine is highly cardiotoxic, and cardiotoxicity can manifest in any form ranging from any kind of bradyarrhythmia to any kind of tachyarrhythmia, and ventricular fibrillation after bupivacaine is not so uncommon, we do see. And if there occur ventricular fibrillation, now the drug of choice is amiodarone. Otherwise also drug of choice for the treatment of ventricular tachycardia is amiodarone. But bupivacaine induced ventricular tachycardia used to be considered best responding to berathylium. So maybe in your books you will find that it is given that the drug of choice for bupivacaine induced ventricular tachycardia is berathylium. But now this does not exist. As per the current recommendations, patient respond better to amiodarone even if the ventricular tachyarrhythmia is caused by bupivacaine. But here the patient has arrested. So obviously we have to give CPCR first, and then the antidote for bupivacaine is 20% intralipid. 20% intralipid. And intralipid, how it works? Simply, it just binds the active form. So it binds the active form of bupivacaine and remove it from tissues. So CPCR with intralipid 20%. A. Question number 4. The image shown below for airway management includes head tilt, chin lift, inline cervical spine sterilization, jaw thrust, head extension. So this maneuver is one of a very basic maneuver that you should know, and this maneuver is actually done to prevent tongue fall, and this maneuver is actually called as triple maneuver. Triple maneuver means head tilt, chin lift and jaw thrust. So head tilt, chin lift and jaw thrust. Head tilt means neck extension, and usually this chin lift and head tilt is done as a single maneuver. Means when you lift the chin, automatically there will be extension of the head. Head tilt, chin lift, and jaw thrust means anterior displacement of the mandible. And this all is done to prevent tongue fall, because the most common cause of airway obstruction in an unconscious patient is tongue falling back on postopharyngeal wall. So manually you can prevent this tongue fall by this triple maneuver, that is head tilt, chin lift and jaw thrust. So this maneuver you can clearly see is head tilt, this hand is tilting the head, and chin lift, this hand is lifting the chin. And after that you should also anteriorly displace the mandible. So then it will become triple maneuver. So obviously this is a manual method of preventing tongue fall. So this is practiced usually outside hospital setup. In hospital setup, you have a very simple equipment to manage tongue fall, and that is called as Gudel's Airway. So this is Gudel's Airway, which is simply placed blindly in cavity so that this part lies in oropharynx, preventing tongue falling back on posterior pharyngeal wall. Question number 5. The most common cause of post-operative admission after daycare surgery is pain, nausea and vomiting, bleeding, respiratory distress. Now there are actually little confusion regarding this question. Few things you have to understand in daycare surgery is, one can be delayed recovery. Like say, I decided to discharge this patient after few hours, say after 3 hours, 4 hours, as per our hospital policy and recovery policy. That is one reason. Second reason is that my daycare surgery becomes indoor surgery, means I was not able to uh, discharge the patient in the daytime, so the patient remain admitted. And so if a patient get admitted in the hospital due to some complication, then definitely it is not a daycare surgery. Daycare surgery means patient should be discharged same day. Third thing is, patient you discharge but they come back to you due to some reason. So these are certain things which causes confusion in these kind of questions. Now, most common cause of delayed discharge is dizziness. And now second most common is pain. Previously people used to say pain, but now dizziness is the most common, you can say, uh, post-op complication of daycare surgery. So some sort of dizziness is there. So obviously if patient is dizzy, one of the criteria for daycare surgery discharge is that patient should be fully conscious, oriented, awake. So most often this dizziness delays our discharge, and dizziness incidence can be as high as 30 to 40%. But after 1 hour, 2 hour, or after some time, the dizziness goes off, we can discharge the patient. So most common cause of delayed discharge is dizziness. And if dizziness is not in the choice, then it can be pain or it can be nausea and vomiting. Fine. Now, most common cause of admission. I mean, admission means from daycare unit, patient going to IP, means patient is remaining in the hospital, or daycare surgery become an indoor surgery. So the most common cause of admission to indoor and readmission after surgery are the surgical causes, particularly bleeding. Okay. So usually patient return after being discharged, coming back to hospital, or from the hospital we are not able to discharge and we have to admit in the ward. This usually is because of the surgical causes, in particularly bleeding. Fine. So most common cause of delayed discharge to conclude is dizziness. However, the most common cause of admission to indoor side is surgical causes, and most common cause of uh, readmission is also surgical causes, that is particularly bleeding. So in this question now you can understand most common cause of post-operative admission means patient is getting admitted to IP side is surgical causes, that is bleeding. Fine. Question number 6. In the image of the below given monitor, the curve marked with the arrow indicates oxygen pressure during inhalation, carbon dioxide pulse oximeter, oxygen pressure during exhalation. So this you can see also clearly written plath. Plath means plethysmography, and plethysmography is the curve of pulse oximeter, and it is showing also, see, 98%. So oxygen saturation is 98%, and this plethysmography is the curve of pulse oximeter. So during pulse oximetry you get curve also. Fine. So this is actually pulse oximeter. And all these are the essential monitors you can see. This is pulse rate or heart rate, you can say, detected from ECG, and these are the two ECG leads, and this is BP, and this is SpO2, and this is respiratory rate, and you can see this respiratory curve is also coming, written also respiration, and this is temperature. So all these essential monitors has been used. If I ask you one essential monitor which has not been used here is capnography. But capnography obviously will be used if the case is done under general anesthesia. So maybe this case is done under regional anesthesia. So obviously will not be using capnography. So this is pulse oximeter curve or graph. What is the mechanism of action of local anesthetics? Block sodium channels, block potassium channels, block calcium channels, block chloride channels. Actually, the latest study have shown that local anesthetics not only act on sodium channels, they can also act on calcium channels, potassium channels, or even chloride channels. So if it is a multiple choice, then all will be the choices. But if it is a single choice, then obviously we will go with sodium channels. So if it is a multiple choice, you can mark all. But for a single choice, sodium, mainly it blocks the sodium channels. And interestingly, it blocks sodium channel from inside. Now say this is axonal membrane and say this is local anesthetic. And to cross the axonal membrane, this local anesthetic should be in undissociated form. In undissociated form, it crosses inside and inside it gets dissociated, and it is this dissociated form of local anesthetics which block the sodium channel from inside. So this is sodium channel. Majority of the drugs, they block sodium channel from outside. So local anesthetics, they block sodium channel from inside. Now whether they block activated channel or inactivated channel, they actually can block activated as well as inactivated channel. However, activated channels are more readily blocked as compared to inactivated channel. So again, I'll tell you that latest studies have proven that they also act on calcium, potassium, or chloride channels. So if it is a multiple choice, you can mark all. But single choice, yes, mainly it is blocking the local anesthetics are mainly blocking the sodium channels. Let me see if there is any doubt regarding some. Okay, no. I'll ask them to send me the link. Okay. Highest fraction inspired oxygen is provided by which of the following? Nasal cannula, venturi mask, non-rebreathing mask, Hudson mask. This is actually something very important, and this actually have become very important in current day scenario of COVID. So you have to know that which oxygen delivery devices produces delivers how much maximum oxygen and how much flow should be there. So nasal cannula, maximum flow you can keep is 6 liter, and maximum FiO2, that means delivered oxygen, is 44%. So this is important, means if you are using nasal cannula at 6 liter, 44 will be there, that is maximum. Now even if you use 10 liter, it will remain 44%. So there is no point in using nasal cannula if you require oxygen concentration more than 44%. Then simple oxygen mask, and simple oxygen mask you know are of two types, Hudson mask and MC mask, McCartney mask. Maximum flow you can use is 10 liter, and the maximum oxygen you can deliver is 60%. Then oxygen mask with reservoir. Maximum flow you can use is 15 liter, and you can give up to 80 to 90%. Some people say 100%, but 100 not possible. Around 80 to 90%. And then is the venturi mask. With venturi mask, maximum oxygen you can deliver is 60%, and that is seen at 15 liter flow. So this is very important to know. So what they have asked now, highest fraction inspired oxygen is provided by which of the following? So it is oxygen mask with reservoir, which you know is also called as non-rebreathing mask. Oxygen mask with reservoir or non-rebreathing mask, NRBM. So it can deliver maximum. How long should elective surgery be deferred for a patient recovered from symptomatic COVID-19 without requirement of hospitalization? 4 weeks, 8 weeks, 12 weeks, 6 weeks. So it is very simple. Although there are many, you can say, societies giving different guidelines, but the most acceptable and more what we practice are asymptomatic patients should delay surgery for 4 weeks. symptomatic but not hospitalized. We delay it for 6 weeks. Symptomatic and hospitalized, 8 weeks. Hospitalized but not in ICU. But if admitted in ICU, so hospitalized means non-ICU, non-ICU patient. But if admitted in ICU, then we have to defer it for 12 weeks. So this is most acceptable. Asymptomatic 4 weeks, symptomatic but not hospitalized 6 weeks, symptomatic but hospitalized in ward, not in ICU, 8 weeks, but if hospitalized in ICU, then at least 12 weeks. So now we can see the question. Recovered without requirement of hospitalization, but symptomatic. Symptomatic not hospitalized means 6 weeks. D. 10. A 42-year-old male patient was under home isolation after testing positive for COVID-19. He develops breathing difficulty and is brought to emergency room. Patient is alert, responsive, but SpO2 patient is 86%. He is administered oxygen via face mask with reservoir bag, means non-rebreathing bag, at a flow liter of 10 liter per minute. After trial of 1 hour, the SpO2 is 88%. What is the next step? Yes. See, this patient, see, normally it's not a standard, but I'll tell you, this patient, if you ask me stepwise, first we will, but it's not a standard step, it depends on the situation. So for patient who is not severely distressed, I will say mild COVID, so first we will start with normal oxygen therapy, and this patient already on non-rebreathing mask or oxygen mask with reservoir, you can say, and this led to hardly any improvement after 1 hour. Saturation from 86% just become 88%, so that's still unacceptable, means we have to go to next step. Now next step, we have two methods. One method is that we can go for high flow nasal cannula, and secondly we can go for NIV. So depending on your you can say resources, or depending on your institutional practice, both are equally good. So you can try high flow nasal cannula also, and you can try non-invasive ventilation also. So in this situation, non-invasive ventilation has not been given, so we are left with a choice with high flow nasal cannula. So high flow nasal cannula means it can deliver very high flow. It can deliver up to 60 to 80 liters per minute. And the advantage of such high flow is that it will deliver some positive and expiratory pressure also, which is very useful in improving oxygenation. So the best in these choices will be high flow nasal cannula. If patient is not responding to say high flow nasal cannula after some time, say after 1 hour, then I will go for non-invasive ventilation. Or I told you, depending on your institutional practice, directly you can go for high flow nasal cannula. So simply I will say stepwise is simple oxygen delivery devices. If no response, then step up to high flow nasal cannula or NIV straight away, or high flow nasal cannula then NIV. And if not responding to any of these, then patient will require intubation. So high flow nasal cannula. Now endotracheal intubation obviously will be much later. Majority of the patients we will be able to omit intubation by high flow nasal cannula or NIV. No specific intervention, no intervention is needed. Now you will say one more choice, why not we are increasing the flow? Because if you increase the flow, you can deliver oxygen concentration. Yes, that is also an option. So we are left with these two choices. But here we already have given 1 hour trial and patient response is not there. So I'll prefer to go on high flow nasal cannula. Yes, Initially 5-10 minutes, if you ask me, if I use 10 liter and I'm seeing that there is no benefit, then I will increase to 15 liter initial 5-10 minutes. And even after 15 liters, I'll see there is no response for say another 15-20 minutes or half an hour, then I'll go to high flow nasal cannula. But here, since trial already has taken one place and patient saturation is still below 90, so it will not be a good idea to do any further trial. So high flow nasal cannula. However, yes, second choice can be increase the flow, but not at this stage. Question number 11. Ventilator support is required if SpO2 becomes less than 90%. Because central chemoreceptors become insensitive to hypoxia below 95%. Peripheral chemoreceptors become insensitive to hypoxia below 90%. Tissue becomes vulnerable for hypoxia. Patient capacity to generate adequate tidal volume decreases below 90%. This is more or less a physiology question, not exactly anesthesia question, but yes, you know that you all have seen oxygen dissociation curve. It is sigmoid shape. It is sigmoid shape, and this corresponds to 90% saturation. So you can see up to 90% the graph is more or less flat, but below 90% you can see the steep fall. So steep fall occurs if saturation become 90 below 90%, and you know that body tissues become very vulnerable for hypoxia. So C. 12. A patient has developed acute biliary colic pain for which Inter had administered an analgesic which has increased the severity of pain. Which of the following analgesic might have been administered? Morphine, nefopam, diclofenac, nifedipine. You know that opioids, particularly morphine, they causes the sphincter of the aorta and can worsen the biliary colic. That you know is a very traditional concept, but very recent evidence has shown yes, they can increase the tone of sphincter of aorta. However, this really does not cumulate into increased biliary colic. So therefore, new guideline says if deemed absolutely necessary, you can even give opioids for biliary colic. However, I think this question may be asked maybe a few years back. So that time our guideline was to avoid or completely avoid opioids. But now they say yes, still you should avoid, but it is not an absolute contraindication. So biliary colic, which used to be absolute contraindication for opioids, is now more or less a relative contraindication. So if deemed necessary, you can give. But yes, since in this question, obviously they are asking that morphine or opioids by causing constriction of sphincter of aorta can worsen the biliary colic. Question number 13. A 55-year-old male patient with history of hypertension on AC inhibitors and has CABG 4 years back is scheduled for hernia surgery. He has good effort tolerance. Which of the following pre-op investigations are ordered? Routine pre-op clinical evaluation, routine pre-op plus clinical evaluation plus stress testing, routine pre-op plus clinical evaluation plus angiography to look for patency, routine pre-op plus clinical plus VQ scan. See, this patient underwent surgery 4 years back. Fine. Now, the very important determinant of patient outcome is patient effort tolerance. METs. If METs is more than 4, that means patient has got good effort tolerance and we can really go ahead with the surgery without getting any investigation. Just clinical evaluation is enough. Yes, if effort tolerance is less than 4, then definitely we have to get a stress echocardiography for this patient. So this patient has undergone CABG and now has got good effort tolerance. So I won't need any further hi-fi investigation in this patient. Simply your routine preoperative examination and clinical evaluation should be more than enough. 14. The following ETCO curve depict spontaneous effort, bronchospasm, esophageal intubation, successful resuscitation. This is called as curare notch. This is called as curare notch. So curare notch is the patient spontaneous effort during controlled ventilation. So what does that indicate? That indicate that the effect of muscle accent has waned off and patient is trying to take his spontaneous breath. So what does that mean? Means we have to repeat the dose of muscle accent. So we repeat the dose of muscle accent usually by curare notch. So curare notch indicates recovery of spontaneous ventilation, means the weaning of the effect of muscle accent. So we have to repeat the dose of muscle accent. So this indicates spontaneous effort. A 50-year-old patient with history of hypertension and diabetes developed the following rhythm with BP 90 to 40, MFG and feeble pulse. What is next step of management? IV adenosine, IV diltiazem, cardioversion, ebultide. See, this is PSVT and but leading to hemodynamic instability, means BP is low and pulse is feeble, means patient is hemodynamically unstable. And for hemodynamically unstable patients, we have to immediately cardiovert the patient. If they are hemodynamically stable, we can try many things. You can try even vagal maneuver. Then you can repeat a dose of adenosine 6 milligram. If not responding, you can repeat the dose of adenosine to 12 milligram. Still not responding, you can try other drugs also. Uh, However, if the patient is hemodynamically unstable, then patient require immediate cardioversion. So C. 16. The position of the patient in the image shown is Trundleberg, reverse Trundleberg, Lloyd Davis jackknife. Head up. Head down position is called as Trundleberg, while head up position is called as reverse Trundleberg. Now, the most important, you can say, consequence of reverse Trundleberg for anesthesia will be decreased venous return. Head up in this position, so there will be decreased venous return. So decreased venous return can cause hypotension, decreased cardiac output and hypotension. So if sudden you go for reverse Trendelenburg, decrease in cardiac output, particularly after spinal anesthesia, because you know spinal anesthesia, there occurs sympathetic block that lead to venodilation and that lead to venous pooling in limb muscles and pelvic muscles. So that decreases venous return and leading to hypotension. And top of that, if you cause reverse Trendelenburg, so that can really lead to profound hypotension. Identify the equipment: mechanical ventilator without a monitor, infusion pump, CPAP machine, high flow nasal cannula. This is high flow nasal cannula that we have already discussed, HFNC. So high flow, I told you, deliver very high flow. It can deliver up to 60 to 80 liters per minute. And the gases are humidified. Obviously, if you are dealing with such high flow, gases has to be humidified. So humidifier is a mandatory part. And this is nasal cannula, you can see. And I told you, if you are generating so much high flow, 80 to 60 liter, that generates some positive and expiratory pressure also. So this is high flow nasal cannula. Blue pipeline in OT is for which anesthetic gas? Oxygen, nitrous oxide, air, vacuum. Blue is for nitrous oxide. So nitrous oxide is blue color pipeline. Oxygen is white. Air is black. And vacuum is yellow. So blue is of nitrous oxide. The given set of instruments used in central line insertion, arterial line insertion, airway management tray, umbilical catheter insertion. So this is airway management tray, and you can clearly see what all these are: laryngoscopes, this is jelly, this is local spray, this is suction catheter, this is Yonkers catheter, this is laryngeal mask airway, and syringe to inflate the cuff of laryngeal mask airway, and this is again jelly, this is stethoscope, this is airway, Goodell's airway, and this is nasal airway, and this is endotracheal tube, and this is endotracheal tube with stillet in place, because sometimes when you are not able to intubate, we have to change the angle, make it like a hockey shape by putting a stellate if larynx is very anteriorly placed. And this is again syringe to inflate this the cuff of endotracheal tube. So this is airway management tray. On your morning walk in park, you noticed an unconscious man lying on the road. Which of the following options indicate the best next steps? Check carotid pulse, start CPR and call for help. Defibrillate if no pulse. Call for help, check pulse, do CPR, defibrillate. Observe and wait till the ambulance arrives. Defibrillate, check pulse and do CPR. Okay, forget the choices. First, let's see what should be the sequence if you find an unconscious patient, and this is outside hospital. So it can be layman also. So first thing is the scene safety. This is very important that the scene should be safe. It is not that building is collapsing and you start doing CPR, then who will do your CPR? Or you start doing CPR in the middle of the road, then somebody or the other side of the road will be doing your CPR. So first you have to make the scene safe. After assessing scene safety, next step is the assess responsiveness. And how you assess responsiveness? By shaking and shouting. Very important, before intervening, you have to just assess the responsiveness. It is not that you activate everything, you start doing CPR and the person may be just sleeping on the roadside. And many times in India, you see people after taking many kind of desi tonics, you will find them sleeping under the tree or even on the roadside. So they just may be sleeping. So you have to assess responsiveness. Now, after assessing responsiveness, now you have to call for emergency medical services. Before doing anything, you have to call for help, because if patient is unresponsive, then you need medical support team. And in fact, if the patient is an adult patient, unconscious man, adult patient, then the cause of cardiac arrest should be considered ventricular fibrillation until put otherwise, and ventricular fibrillation only responds to defibrillation. So you have to get the defibrillator at the earliest. Fine. So you have to call for help. After calling from help. Now, calling help maybe with the app. You have to simply press that app and automatically through GPRS they will detect your location, but that's not applicable in India. We don't have such kind of app. All kind of apps are available in our phone, including pizza apps, burger apps, or undergarments app may be there, but not the app of life. If that is not there, obviously in that setup you can call helpline, central helpline 1099. Different countries have different number. India 102 still is there, but that still is not very often functional, unfortunately. Then you come back to the patient and then you assess patient breathing and pulse simultaneously. Pulse assessment by palpating carotid and breathing by simply scanning at the chest movements. And if patient is pulseless or breathless or both, then you have to start CPR, starting with cardiac massage, then airway, and then breathing. And cardiac massage means you will be giving 30 compressions over a period of 20 seconds, and then airway and then breathing. And continue your CPR till the defibrillator arrives, and then defibrillate as soon as the defibrillator arrives. Now look and look. So uh, so best is check carotid pulse? No. Call for help, check pulse, do CPR, defibrillate? Yes, this is the best option. So first assess responsiveness, then call for help, but assess responsiveness is not there. So already means that has been considered, you have already done that. So now you call for medical services, then check pulse and breathing, start CPR and defibrillate. You cannot just observe and wait till ambulance arrives. You have to start CPR. Yes, if pulses are palpable and breathing is also there, then in that case you will observe and wait. But obviously before that you have to assess and confirm that patient is not pulseless, not breathless. 21. Match the following dilution of adrenaline and its use. 1 in 1000, 10,000 and 1 in 1 lakh. Cardiac arrest and fire. For cardiac arrest it is 1 in 10,000. So 1 is B. Anaphylaxis, 1 is 1000 and that is IM or subcutaneous. Mostly IM. Local anesthesia is actually 1 in 2 lakh. But if you dial, so actually it is 1 in 2 lakh. But since we have no other option, so it will be 1 in 1 lakh. So 1B, 2A. A is A is 2. A is 2. Okay, fair. Choice B. A is 2. B is 1. Yes, and C is 3. Yes, B choice. Which of the following is the most commonly method used to know the depth of anesthesia? Bispectral index, esophageal contractility, depressed response, hypotension. Bispectral index monitor, popularly called as BIS index. Actually, until BIS index, we were mainly relying on clinical signs to see the depth of anesthesia. But BIS is highly reliable. It is a very simple device. You just place over the forehead like electrode, like ECG electrode placed over the forehead and attached to the monitor. It analyzes multiple EEGs to give you a final score. So you don't need any interpretation also. So for a fully conscious patient, it will exhibit a score of 100. For brain dead patient, it will exhibit a score of 0. To say adequate depth, this score should be between 40 to 60. If it is more than 60, that means patient is in light anesthesia. Less than 40 means patient is in deep anesthesia. So this is really very useful. Now commercially available also. Anesthetic gas with maximum respiratory irritation. Halothane, enflurane, desflurane, sevoflurane. Desflurane. Desflurane is an ethereal product. Desflurane and isoflurane both have irritating induction, and induction can be even associated with laryngospasm or bronchospasm. So therefore, actually they must never be used for induction. For induction, normally for adult patients we induce with IV. For pediatric also we prefer IV induction, but very often the child will come to us without IV cannulas. So in that case, we have to directly induce the child with inhalation induction. So in that case, inhalation induction is of choice is sevoflurane. Smoothest, just wait for some seconds till this ajan is finished. Now let me see if everything is going fine. So desflurane got maximum, you can say irritant desflurane isoflurane, while sevoflurane and halothane has got very smooth induction. Which of the following is not cardiodepressive? Propofol, thiopentone, ketamine, etomidate. Yes, most cardiac stable IV agent is etomidate, making it as an IV agent of choice for all cardiovascular patients, cardiac patients as well as even vascular surgeries. Etomidate, most cardiac stable IV agent. IV administration of which anesthetic drug is most painful among the following? Methoxytone, ketamine, propofol, etomidate. Methoxytone and ketamine are non-painful. Propofol and etomidate both are painful. So you have to choose one. So we'll choose here propofol. Why? Because propofol is an oil-based preparation, so it will cause pain in each and every patient. Etomidate causes pain because it can cause thrombophlebitis, the incidence of which is less than 10%. So it will cause pain in around 10% of the patients, while propofol will cause pain in every patient. So I definitely will prefer propofol over etomidate in this situation. 26. A 3-year-old undergoing squint surgery. Initially heart rate was 140. After anesthesia and starting surgery, heart rate is 40. Next appropriate step, stop surgery, decrease plane of anesthesia, injection glycopylate, injection atropine. So this is oculo cardiac reflex, which is very important reflex during squint surgeries. And in fact, this has led to few cardiac arrests also. And this happened because of the manipulation of ocular muscles, particularly medial rectus. So if patient start to develop bradycardia, that means, and this oculocardiac reflex mainly manifests as bradycardia, in fact, which can proceed to asystole. So here, when the patient start to develop bradycardia, first thing is you immediately ask the surgeon to relieve the stimulus, means to stop the surgery. As soon as they remove the stimulus, this bradycardia gets settled, oculocardiac reflex gets settled. If not, then obviously you have to give atropine. So first step would be stop surgery. If not, then we will give atropine. 27. Circuit of choice for spontaneous ventilation. Mefalson A, Mefalson B, Mefalson C, or Mefalson D. For spontaneous ventilation, it is Mefalson A. And for controlled ventilation, you know it is Mefalson D. 28. Most common nerve used for monitoring in anesthesia is facial nerve, median nerve, radial nerve, ulnar nerve. Ulnar nerve. Ulnar nerve, actually most commonly used muscle is adductor pollicis supplied by ulnar nerve. Actually ideal is facial nerve, that is corrugator supercilii or orbicularis oculi, practically. Why? Because they parallels with the laryngeal muscles, but it is not possible to put electrodes over eye and face, so therefore we are not using, and most commonly we are using is adductor pollicis supplied by ulnar nerve. Murphy's eye is a part of endoscope, endotracheal tube, Ryle's tube, LMA. Murphy's eye is an additional hole seen in PVC tube, polyvinyl chloride endotracheal tube, this hole. You can see this additional hole. This is Murphy's eye. So if even main lumen get blocked, it is possible to ventilate patient through side hole. This is called as Murphy's eye. 30. Modified Malamparti grading is used for the assessment of difficult intubation, airway obstruction, death due to aspiration and intubation. So modified Malamparti is used for assessing difficult intubation through oral cavity. So in Malamparti, what we do? We ask the patient to open mouth as wide as possible. Then looking at the structure seen, patient has been categorized into 4 categories. So Malamparti grade 1, you will be able to see all structures, and 4, you will not be able to see any of the recognized structures. So obviously intubation, oral intubation will be impossible in grade 4. So it is to assess the difficult intubation through oral cavity. Fine. So I think these are some of the questions. Now we can take up the queries. I'm just opening the link. So you can post your queries and I'll see queries. So I'll start from the beginning. 553 operating room technology. Sir, drug of choice for ECT is methotrexate according to your book. Practical I have seen we use thiopentone as an induction agent of choice for ECT. You are right, because actually uh, methotrexate is practically not available. In fact, we are using propofol. Thiopentone is actually not advisable. It is anticonvulsant, but propofol we can use. Yes. See, the thing is, many things what we do practical are different from what are ideal. So therefore, we obviously in questions we have to go what is the best. So drug of choice is definitely methotrexate, but methotrexate is hardly available, hardly available. So that is why some people are using thiopentone or some people are using even propofol. But still, drug of choice is definitely methotrexate. Mm, okay, sir. Another question, that who can do PhD in anesthesia? Can MSc in knee anesthesia technologist can do it? I really don't know about PhD programs are being done here in India or not, because here it is mainly MD or DM. Yes, in West PhD programs are there. So I'm really not very sure about it. I think operator technologist, MSc in operation theater. So I think you can pin me personally, then I can recommend you something. Not in this group, so please pin me whenever you feel like. Okay, any other queries? You can just post your queries fast if you want to know anything, any doubt. Mechanism of capnography in hyperventilation. Uh, I did not get your Subham question. Capnography in hyperventilation, or maybe you want to ask that why we hyperventilate to decrease ICT or something. Can you please clarify your question a little bit? Mechanism for malignant hyperthermia, Priyam Shah. Malignant hyperthermia because of the abnormality of calcium receptor, that is ryanodine receptor, and the abnormality of that lead to accumulation of calcium in sarcoplasmic reticulum, and that lead to sustained muscle contraction, and this sustained muscle contraction increases muscle metabolism, and that lead to heat production, and that leads to hyperthermia. Fine. So can you please qualify, Shubham? Okay. In hyperventilation, CO2 will be low. Hyperventilation washs out carbon dioxide. So if there will be less CO2, so obviously CO2 is low. Normal CO2 is say 38. Average, you can say 35 to 32 to 42. So say 36, 37. So it will be less. Fine. Mapleson circuit diagrams. Let me see if I can show you some diagrams. So this is Bain circuit, and in Bain circuit actually there is an inner tube and an outer tube. So you have to identify this. You can see this inner tube going all the way. So this is Bain circuit, and this is a pediatric circuit, Jackson and Rees. So this is a T piece, and then there's a test tube, and then there will be a valveless bag. So this is Jackson Rees. And McGill circuit, third McGill circuit, this is the McGill circuit, single tubing. Fine. At one end there is a bag attached, and other end there is a mask attached, or you can attach endotracheal tube to it. So these are the, I think, three circuits that you should know. Any other doubt, or should I end up the session? Okay then. I don't think there is any other query. So I'm wrapping up the session. So no, anyways, you still, if you have any doubt, you are always most welcome to face on our to post your queries on our Facebook, eGurukul, and we definitely try to help as much as possible. So thank you very much for attending the session, and my best wishes. Okay then, bye.